Thank you very much for that. You definitely don't want to hear me talk about vitamin D supplementation. Just by way of overview of my presentation today, and seeing we've got a speaker missing, if I may endure a few extra minutes, hopefully, if this goes over time. So talk a bit about atrial fibrillation, its consequences, and then talk about some of our left atrial studies and get on to the prothrombotic effect post-catheter ablation. So atrial fibrillation is the most common sustained cardiac arrhythmia. It's affecting approximately 2% of the unselected population. As we can see here, the dark line in the centre is the approximate average percentage of atrial fibrillation. So over the age of 85, atrial fibrillation affects approximately 15% of the population. It's thought that 1 in 4 people in their lifetime will develop atrial fibrillation. We know that atrial fibrillation is an emerging epidemic, and there's been a dramatic increase in AF-related hospital admissions over the last 20 years. So if we can look at the summary data here from our group published a few years ago, we see that AFib in black has increased in hospitalisations in Australia, where others, myocardial infarction or even heart failure admissions have gone down. And of course the incidence of atrial fibrillation is predicted to increase. Now, atrial fibrillation by itself generally isn't life-threatening. However, if left untreated, the side effects can be potentially life-threatening. Atrial fibrillation is associated with a high risk of mortality and morbidity from stroke and thromboembolism. This increased risk is 5-fold versus the general population, but as much as 17.5-fold in high-risk populations such as rheumatic heart disease. It's thought that somewhere between 15 and 40% of all strokes may have AF etiology. And of course we know that the prevention of ischemic strokes managed through anticoagulation. However, there are still some bleeding complications that may arise. Thrombus formation in atrial fibrillation largely occurs within the left atrium, but the mechanisms for this are complex and still remain poorly understood. There are local factors from the left atrium that may contribute to the heightened risk of thrombus formation, these being atrial mechanical dysfunction. We know the abnormalities of clotting factors, endothelial damage dysfunction, increasing role of inflammation, and predominantly the interest of my area of research or platelet activation. So I'll quickly just remind people what platelet activation is. We know that platelets are generally short-lived and are the smallest blood elements. They have a lifespan of about 8 to 10 days, and we know that they play a major role in homeostasis and maintaining blood vessel integrity. But upon activation, we know that platelets dramatically change their shape. They also release their own prothrombotic factors from their internal stores. They interact, importantly, with other blood elements, fibrinogen, the blood vessel wall. We know that platelets play a major role, or have a major role, in coronary artery disease, diabetes and hypertension. Platelet function, increased platelet activation has also been shown in patients with atrial fibrillation. However, there have been inconsistent results in the literature, generally because platelet function has been measured at the periphery. We know that platelet formation generally occurs within the left atria, therefore it might be more important, or it is more important, to measure from the cardiac sites. In addition to evidence that we have studies that from Chen et al. A few years ago, looking at patients with rheumatic mitral stenosis, and when blood samples were taken from the left atria, the right atria, the femoral vein and the femoral artery, we can see that left atrial platelet reactivity, here measured by platelet p-selectin expression, is significantly increased from the other sites. In a study in JACC by Joseph Acker a few years ago, they showed that acute onset atrial fibrillation is associated with increased platelet activation and endothelial dysfunction. And here we have platelets sampling from the coronary sinus, and we also have platelet sampling from peripheral site. And we have on both sides of these graphs AF induction, and then we have an equally paced group. If we look at the blood sampling at the atrial fibrillation site, in the white bars is post-AF induction. We can see a dramatic increase or an increase in platelet reactivity. However, when measured at the peripheral site, there's no change. So this led us to suggest that atrial fibrillation is definitely inducing platelet reactivity and thrombotic response. However, the previous study sampled from the coronary sinus, so we conducted a study published in JACC a couple of years ago to look at the effect of atrial fibrillation on atrial thrombogenesis in humans in blood samples taken from the left atria, and the impact that rate and rhythm had on these the measures. So the aims of the study were to investigate the acute onset atrial fibrillation on the left atrial thrombogenesis. We looked at platelet function, activation, thrombin generation, endothelial dysfunction and inflammation. And we also tried to determine which is more important, rate or rhythm. So we had 55 patients undergoing a catheter ablation who were in sinus rhythm at the start of the procedure. We broke the groups into a group that was induced into atrial fibrillation, a group that was paced at an equivalent atrial rate, and a group that we essentially did nothing to. It was just the passage of time as a control. We took blood samples from the left atrial, the right atrial and the peripheral circulation. Our measures of platelet activation, we looked at P-selectin, platelet activation receptor, thrombin complex as a measure of the coagulation cascade, asymmetric dimethylarginine or ADMA as our marker of endothelial dysfunction, and soluble CD40 ligand as a measure of inflammation. The next few slides are colour-coded the same. In blue we have our peripheral sample, in green we have our right atrial sample, in red we have our left atrial sample, and we have a summary of the results down here. It's probably easy to go through the summary of the results. Here we can see for intracardiac platelet activation in our controls, passage of time actually decreased platelet reactivity, where both atrial fibrillation and pacing induced an increase in platelet activation results. If we look at thrombin generation by thrombin antithrombin complex, again looking at the overview here, we'd see again we had a decrease in our control group. We had a small increase in responsiveness in our AF group, and we had a larger increase in thrombin generation in our pacing group. When we looked at endothelial dysfunction, we see an entirely different pattern. Very little change in our control group, a marked increase in our AF-induced group, and no increase in our pacing group. And the same pattern occurred for inflammation and inflammatory response. Nothing in our control group, increase in our AF-induced group, and nothing in our pacing group. So this led us to conclude the acute onset of atrial fibrillation and rapid atrial rates both affect platelet activation and thrombin generation. However, it is only acute onset atrial fibrillation which induces endothelial dysfunction and inflammation. These findings suggest that both rapid abnormal rhythm and rapid atrial rates contribute to the thrombogenic risk in atrial fibrillation, and naturally that further work to understand the significance of these findings and the contribution of both rapid atrial rates and atrial fibrillation to thrombotic risk in atrial fibrillation was needed. So we've now shown that inducing atrial fibrillation is bad from a thrombogenic point of view. However, what is unknown is what happens when we reverse atrial fibrillation back into sinus rhythm. This is generally done, or one method of doing this is by radiofrequency catheter ablation for atrial fibrillation. So radiofrequency ablation is known to increase markers of inflammation and myocardial injury. patients undergoing radiofrequency ablation are also at an increased risk of having a thromboembolic event in the first 2 days post the procedure. Ooh, I'll go back. However, the exact mechanism for this increased thrombotic event is unknown. Previous studies have shown that post-cardiac ablation, catheter ablation, increases inflammation, C-reactive protein, or decreases C-reactive protein at 3 months in patients who maintain sinus rhythm for that time, suggesting that atrial arrhythmias contribute to the inflammatory process. So if you decrease, so CRP levels go down if you maintain sinus rhythm, however they go up if, or don't change, if you continue to have recurrence of atrial fibrillation. So most studies have used various reasonably long time frames, 0 and generally 3 months or longer than 6 months. Little is known about the specific time course of the inflammatory responses post-atrial ablation. So we conducted a study published last year to study the time course of markers of inflammation, myocardial injury and thrombosis following radiofrequency ablation, and to study the relationship between these markers and recurrence of atrial fibrillation. Looked at 90 consecutive patients undergoing radiofrequency ablation. We took baseline blood sampling, in this case peripheral, so that we could match follow-up sampling. Patients had a catheter ablation, either a pulmonary vein isolation and a linear ablation, but also had complex fractionated electrogram ablation as well. Clinical review and blood sampling occurred at 1, 2 and 3 days and 1 week, and follow-up blood sampling were also taken at 1 month, 3 months and 6 months. Markers of inflammation was high-sensitive C-reactive protein and white cell count. Looked at troponin and CKMB for myocardial injury, and we looked at fibrinogen levels and D-dimer for thrombosis. Conclusion, all patients were over 18 and had various types of atrial fibrillation. We did exclude people who had recent myocardial infarction, who had surgery within the last 3 months, or had various other diseases that could initiate atrial fibrillation. Here are our patient characteristics. So there's nothing standout. This would represent a normal atrial fibrillation population presenting at our hospital. When we break patients down into the proportion, majority had paroxysmal atrial fibrillation, about 30-35% had paroxysmal, and 10% had long-standing atrial fibrillation. And then if we run through the list here, we have all the characteristics of how many had the various types of ablation, PVI only, PVI and ablation. Majority of patients had a complex procedure of PVI linear ablation and complex fractionated electrograms. Ablation time was high but varied depending on the type of atrial fibrillation, and these will factor into our multivariate analysis later on. Here we have our results. Here we see that we have an increase in a C-reactive protein that occurs and peaks at 3 days post-procedure, whereas for a white cell count it peaks at 1 day and is still elevated up to 7 days. Myocardial injury, we have a sharp rise and peak on day 1, still elevation up to day 3 post-procedure, and then return to baseline levels 7 days post. And for our other cardiac marker, CKMB, we again have an increase at 1 day, 2 days, and then return to baseline levels after that. In contrast, if we look at our markers of prothrombotic response, our prothrombotic markers occur a little later. They peak around the 3 to 7 days, no early elevation. If we look at D-dimer, again, it's that 3 to 7 days, but out to 30 days post that our markers are elevated. We also were interested to see if any of our markers correlated with atrial fibrillation recurrence. So in our whole population, 40 patients had no atrial fibrillation at any of the clinical follow-up. 19 patients had atrial fibrillation early on. 22 patients had atrial fibrillation as we characterised at 1 month and 6 months. When we used the predictors of recurrence for age, history, ablation approach, ablation time, and then changing our markers, only inflammation, myocardial injury, and thrombotic markers were associated with as predictors of AF recurrence. So here we have, if you had atrial fibrillation recurrence versus no atrial fibrillation recurrence, high sensitivity CRP was associated with an increase, but again, this was only in the intermediate, so short, within 30 days. Was not associated with atrial fibrillation prediction out to 6 months. And if we looked also change in troponin level or CKMB were also associated with atrial fibrillation recurrence. However, this was in the early time frame, so atrial fibrillation within 3 days and not at 3 months or either 6 months. Similar to the pattern, we show that changes in fibrinogens was associated with both the intermediate, so a short term, and also a change at 1 month, but not change at 3 months, or change in thrombin level wasn't associated with AF recurrence at 6 months. So in conclusion, patients undergoing a radiofrequency ablation for atrial fibrillation exhibit an inflammatory response and myocardial injury that peaks within the first few days post atrial fibrillation. And the extent of inflammation and myocardial injury is linked to immediate and early AF recurrence. So targeting an inflammatory response early after a procedure, the radiofrequency ablation procedure, may aid in the maintenance of sinus rhythm post-atrial fibrillation. And the prothrombotic markers elevated 1 week post-catheter ablation are associated with inflammation, but also may explain the early increase in thrombotic events post-atrial fibrillation. What is important about the importance of targeting the inflammatory response early after the radiofrequency ablation is important in our eyes, and we have studies currently underway to see if that can alter the amount of patients who develop or redevelop atrial fibrillation in the first few months following their procedure. Thank you.